It's 10:02 on my clock, so I'm going to convene this hearing of Division 3 Finance. Today's subject is an informational meeting. This is a meeting that we've asked the department to come in and talk to us about issues that are not directly related to the budget, more like programmatic issues. So today, I'll ask the committee members to be careful to not ask any questions related to an answer that may require a dollar number. We're not doing dollars today. We're doing programs, growth of programs, plans for programs effectiveness, that sort of thing. We're going to have Commissioner Weaver, I believe, start, and you may want some people to join you, whatever you please. Yeah, please. I always take the really big chair. I just, yes, yeah. Yeah, I think they caught me on film standing up and having a chair stick to me, so. Yeah, blame me. Before you get started, I want to do just a little bit more setup on this. I have appreciated over the last 4 years, the last two budget cycles, the honesty and transparency that this committee has received from every member of the Department of Health and Human Services. I am optimistic that transparency and honesty, there's no reason to doubt that that's going to continue. The reason why some may be concerned about it is I think anyone who's reading the papers understands this is going to be a particularly difficult budget cycle. We have everyone from the governor to the DRA to others letting us know that our revenues are probably going to be less optimistic than what we might want. And it is our deep obligation as a finance committee to deliver a budget that stays within the available revenues. It would be nice if we had endless revenues and we could have unlimited wants and unlimited needs met, but that's not going to be this cycle. So as we kick off, Commissioner, members of DHHS, members of the committee, I can anticipate a year in which there's going to be frustration during the process, and I just hope that we can continue to maintain the professionalism with each other throughout the course of this. So thank you very much.
Thank you, Representative Edwards. Good morning. My name's Lori Weaver. I'm the Commissioner of the Department. Today I have my senior team with me here, Nathan White, CFO, and other members that you'll meet shortly. What Representative Edwards has just references, this is our attempt, and we're grateful to have the opportunity to have this conversation with you, to be able to tell the story of the department without having you glaze over and us go line by line. You're going to have that part when we get to the budget for sure. But really wanted to have a chance for you to really understand the functions of the department. And we're going to try to do that today, this morning at a high level. And subsequent presentations, we'll do a little bit of a deeper dive. So what I was really hoping for today is to have some time at the end that should you have questions as we go through, and you might have a detailed question, to sort of jot that down. And at the end, I'd like to collect those to be able to make sure that my team is able to respond in the subsequent presentations and weave that question that you have into our responses, if we have time for that. At the end, we'll make time for that. So I believe in front of you, you have a handout, which is a PowerPoint. It looks like this. So this will be sort of our guide for today. You have a couple of things in front of you. I also shared our roadmap, which I'll talk about, and then there's also this one pager, which for those of you that may not be as familiar with the department, it lists obviously our mission and our vision and our responsibilities, but every division that the department has in terms of how it breaks down. And sometimes that's a handy reference for when you're looking for, well, where does something fall? You could put it into there. So today, how we've structured the time with you is really, I'd like to go over some facts and figures, so a little bit of numbers, but just in terms of setting perspective. Talking a little bit about our roadmap, which is really a framework for our priorities. So we've been working with a roadmap now for a couple of years, and it's a way for us to lift up the work, to be able to say, hey, this is what we're charged with, this is what we're responsible for, and this is where, hopefully when you get to budget, you'll be able to crosswalk and do some tying in with that. The next couple of bullets are really about the thematic focus of when we're looking at what is the department focused on. Really efficient stewardship and strong customer service. That is a theme not only throughout our roadmap, but through all of our work that we do. And we'll talk about that in a little bit more. Increase access to prevention and specialized services. And why is that important? Especially when we're thinking about cost, right? We're really talking about keeping people in communities and keeping the levels of care that are appropriate to their need and budget appropriate as well. And then we can't really talk about Health and Human Services without having some conversation about Medicaid. So I think we have a separate Medicaid 101 that Director Lippman is going to provide. That will be a deeper dive. But I think for the purposes of today, to sort of give you the framework of how does Medicaid play into all of the programs and policy areas at the department. And then lastly, some of those questions. So if that sounds good, Representative, I keep going? Okay. So a little bit on the facts and figures.
I'm sorry, I'm just a little slow. I had meant initially to point out that Representative Tulerski had let us know she's going to be about 15 minutes late, so she's on her way. And I don't know where Representative Narvanko is, but he may come in. I've got a request from Representative Daniels to allow him to leave at 11:15. I think you want to leave it around a little bit before 11. So we'll just try to keep moving.
Yep, thank you. I believe we'll get there. This is sort of a high level view. Really, our vision for the department is really about our citizens in the state having optimal health. That is our goal, and the department plays a big role in that. We have three primary responsibilities. If you think about, well, what does the department do? It's so large. You can chunk it out into protection and prevention, client service delivery, and regulatory oversight. So as I've mentioned, we have 8 divisions. 6 of those are direct policy or programmatic related divisions as they're listed there. And then we have 2, which the Division for Finance, which Nathan, our CFO, oversees, and then our Quality Improvement and Integrity unit division as well. So that's the bulk of our organization. When you look at some numbers, yes, for this fiscal year, we have a $3.6 billion budget. Obviously, that's not all general funds. We have a lot of federal and other revenue sources. So that's a lot of money, and we're about 53% of the in total state budget for general funds. And our staff represent, when you think about all of the state positions, I think last I knew there was around 12,000. We're about a fourth of all state positions. But yet, when you look at our budget, our personnel costs are really less than 11% of our whole budget. So I just wanted to point that out, that oftentimes when we think about reductions in budgets, the first place we go to personnel, and for sure, and that's something we do every single year, whether it's a reduction year or not. Obviously mindful of that this year. There's just recently a hiring freeze, which will obviously is going to impact our ability to hire, but that 11% isn't necessarily where the money is at for a big chunk of reduction. There's some for sure. And then, sure.
For the folks who are new to this $3.6 billion budget, as I understand it, is federal, state, and other sources. Correct. Of which the general funds is about 1.217 billion. So about a third of the total budget, I understand, is general funds.
I will say in my commissioner rough estimates, yes, but Nathan will give you the exact.
Yes, that's roughly correct.
All right. Thank you. I just wanted people following to see what the numbers are. You're over. Yeah. All right. Welcome. I'm glad you're safe. You continue.
So, and just continuing a little bit on the next page for staffing, this is how our position counts break out. So I just want to point out that with the exception of any required legislation, the department did not make any new position requests. So we go through every spring being prepared for that. We made none except for what was legislatively required of us. 50% of what you're looking at here, 50% of our workforce roughly is what we call direct care. So client facing or client serving. That's why you'll see larger numbers in DCYF or in economic stability or at New Hampshire Hospital. And then obviously, you have Medicaid. To your point, we have a lot of money in our Medicaid service. We have about a team of 33 in the Medicaid space. As opposed to some of the other areas. So we have a legislative cap of cannot go over 3,000. Approximately, we're about 11 shy of being at 2,800 filled as of today. I do expect that to change with the hiring freeze and attrition will happen. We do have some carve outs for direct care, but attrition is constant. So I do expect that number to change. In the last 2 years, we've reduced our vacancy rate quite significantly from 22% to 14%. So there was a lot of effort that went into that, and then trying to retain those staff and keep those staff. Again, a hiring freeze, I expect to see that number start to move again. And ultimately, it matters because that's going to really dictate if I don't have workforce, there's some things I can do and some things I can't do. The next slide is really on our budget complexity, and I'm going to let Nathan explain this one, but in terms of a little bit about what Representative Edwards was saying earlier, our budget is not just one funding source. However, there's lots of other requirements and some complexity to how it all works.
Great. Good morning, members of the committee. Nathan White, Chief Financial Officer. Good to see some returning members. I look forward to working with new members that I haven't yet had an acquaintance with. This slide in front of you, I know we're not going to be talking too much about budget, but I don't necessarily think you can talk about the programs, of course I'm biased, without talking about the budget. And in front of you, this slide, it presents some of the dynamic nature of HHS's budget. And one of the reasons that some people sometimes have a challenge understanding why is HH budget so complex. And the saying that I always like to say is, it's complex, but it's all explainable. And so if you look at the first circle there, that is the budget. And so we prepare our budget, the agency budget in August. We make certain assumptions. We assume we're going to have X amount of vacancies. We assume that we're going to have X percentage of clients for this particular service. We assume these expenditures are going to be X based on a certain population. And then we have the actual. So once the budget is passed, then we move into the actual, and then we see what really happens. And you have to remember, we prepare our budget, our agency budget, 10 months before the budget actually goes into effect. So because our budget, again, it's a little over a tenth personnel. Most of our budget, a lot of our budget is in Medicaid. It's in direct services provided to citizens. There's contracts. And we don't necessarily know what that spending is going to look like, because that spending is going to be responsive to the needs of the population of the citizens of the state. And then there's a third component, you'll see that bubble on the right, cost allocation. And so HHS, we use a cost allocation system. We have it's called a PACAP, a Public Assistance Cost Allocation Plan. It's a several hundred-page document. I don't recommend reading it. But what that does is it basically lays out the framework in which we're able to leverage federal funds, and we assign those federal funds towards certain efforts. So for example, some of our employees may be paid with a couple of different funding sources. It might be TANF dollars, it might be 4E dollars, and they do random time studies during the month and random moment studies and some other methodologies. And then we assign, okay, you worked on Title 4E projects a certain amount, that means you get to earn more 4E. And we go through a regular process, and we have a team that does this to make sure that we can leverage those federal funds. And so it's these three components that kind of feed into the HHS budget. And then on top of that, like when you're thinking about sort of the middle here, there's other complexities on top there where you have maintenance of effort requirements. So one of the topics that we discussed, Representative or Chairman Edwards, last time a lot was TANF. So we have to spend $34 million of general funds in order to get, or excuse me, 32.4, in order to get $38 million of federal funds each year. And if we don't spend X amount of general funds, then the subsequent year we have an equal penalty, and then we have a reduction. And so sometimes when you're looking at positions, you go to abolish this position. Well, yes, but that may impact our ability to spend towards that TANF MOE. And I just kind of want to recognize those complexities before we start getting into some more of the details, so that when we say, oh, well, what does that contract do? That contract does this, but you have to remember that also helps us meet our Medicaid requirements and things of that nature. So I'll kind of pause there and hand it back over to the
Can I ask
commissioner.
you a question then?
Yes.
So, so that suggests that historically, then, that you've done an accounting to show how we accumulated our TANF contribution, and that that would give us some sense of how divergent those sources of contributions are. Could you, is there something simple enough? Is this like 5 pages of spreadsheet, or is it 100, or what would we be looking at if you were to share with us historically looking TANF contributions?
We would probably want to simplify what we have internally, but I could take it back to the team and we could see what we could put together to kind of demonstrate, because that match is going to be met by many different positions
Right.
in many different areas
Right.
and contracts and other factors. But I don't want to get too far into the weeds today.
No, I don't want to either. I'm just asking you if you could provide it in a way in which we could get a sense of how complex it is that you just described us. Because I agree with
Yes.
you that it's an important factor for us to understand how embedded and intertwined these contributions can be.
We can do that for you,
All right,
absolutely.
thank you.
And so before we leave that, I just, in terms of positions, one thing that we worked out last biennium, budget-wise, is in terms of, with positions, letting the department being able to hit a target rather than going through and this position and that position, knowing the complexity of what is behind each position for funding mechanism. Okay, so moving to the next slide. So the roadmap. So you have, I shared with each of you a hefty document. It's also available on our website. I printed out the color copy. Only special people get the color copy. Being mindful of resources. Our roadmap is really our framework, right? So this is the department's priorities. And what I'd like to be able to do today, as I walk through high level for you, is also weave in some of those themes that I was talking about earlier of what we're focusing on here. Our roadmap was, just for brief history, short, mid, long-term goals developed internally and with stakeholders. So we didn't do it in a vacuum. We went and got feedback on it. Our staff at all levels have participated in working with the team to lift this up so that there's ownership and that people understand the work. So it's not creating new work. It's a frame of same work of the work. And it's a way for us to be able to say, when people say, what are your priorities, department? We're able to point them to this document. So it breaks down into about the three different bubbles that you have in there. I call it the 3 C's: culture, community, and customer service. So if we look at I'll start with the bubble, the purple bubble, promote thriving communities. Really, this is where a lot of our policy work is. This is about client services, the right service at the right time for the right individual. When we think about what is some of the themes that we're looking at, is really access to specialized services. So we have a lot of our different programs in here that you're going to hear about, but we have a high focus on making sure that there is access for people to receive those services that they need it. The bullets beneath it, I should put my glasses on. These are the main initiatives under there. I'm not going to go through all of them as you're going to hear about them. I just want to highlight a couple for you. Some of you may have heard about Mission Zero. That is one of our initiatives and priorities about ending emergency department boarding. So we've had a concerted effort over 2 years with our partners, internal and external, to be able to bring the number down of folks sitting in EDs. So when you say, what is your priority? Priority is to make sure right service, right person at the right time, right? That people don't have to go to the highest level of care. If they're experiencing a mental health event, there may be lower levels of care. So that is something that we've had a focus on, as well as quite a lot of success on. Moving down in sort of in the middle of it is improve access to a broad range of community-based and residential behavioral health services. So that's not only for children in our system, but that's also for our adults as well. And so you think about in-home care services, not for some of our seniors and older adults, but also for kids. Not every kid needs to be in a residential placement. What is the continuum spectrum of services that they can be receiving to keep them out of res care? So that is a priority for the department, is to reduce reliance on institutional care and to be able to increase community-based care. So you'll hear that theme throughout, and that ties in a little bit with our system of care for healthy aging, which you'll hear more about as well, but there's been a lot of progress on that front as well. So we have two systems of care. We have one for children and we have one for adults, pretty much with a primary focus of trying to keep folks in their communities while receiving services. So that's the bulk of our work. The customer service side of it, that bubble on the bottom there in the middle, that falls into our theme of efficient, effective use of our resources, right? Are we being efficient and mindful of what we have, how we're spending it, and how it's being utilized? And also strong customer service. So I'll just highlight a couple for you here. In terms of the contracting experience, when you think about the dollar amounts that we have invested in our contracts, a lot of that money is given to our providers and state to provide these services, right? So whether they're community-based, whether they're or more intensive. Okay. I was going to say, it's not my chair that's shaking, Ellie, right? Okay. Woo. Boy, talk about sweating, huh? Not in California, okay. I got to recollect my thoughts there. So my point being is for contracted services, a couple of points here. So if we are responsible to make sure that we get people served, and we draw down this money and we have all this money, and now we've got to procure it, we've got to get it out into services, which means we've got to work with our partner providers in the community. So a couple of things here. From the external side, for the last 2 years, I've focused with our Center for Nonprofits organization to work with all of our providers to say, how can we do this better? So we isn't just the department, it's obviously the state. If you know anyone, if you have a colleague, anyone that says, hey, I want to do a contract for the state, they're a great vendor, but sometimes it's really hard with a lot of bureaucratic processes and paperwork. So we're trying to make that easier at the department level and beyond that, because we need our provider partners. They carry out this work. It's not the department staff that do it. So there's that external side to make sure that we get good provider partners. The internal side is our making sure that we asked and contracted for the right things, right? What are we investing in? What is the outcome? What are the deliverables? And are we getting it? So there's a couple of pieces there. There's good contract management writing. There's good negotiations with vendors, partners, but there's also measuring the outcomes as we go along. So good active contract management. So we as a department are responsible. If we're going to take this money and put it out there, we need to all along the way make sure that it's hitting the mark. And if it's not, to be able to course correct so that we don't get at the end of a 2-year contract and say, well, yeah, that didn't work. And then we have all that money that didn't get us to where we needed to go. So that has been a big focus of our roadmap, and efficient stewardship of our resources. That's a big piece of it. Another piece of it is our data-driven practices. So really trying to increase our use of data and dashboards with all of our services so that we can look at what is the data telling us for where we need to drive for that service, not where we've driven for 30 years or where we think we need to go, but where the data tells us to go. So that's helping with future planning, and it's also helps with current management as well. So, and there's a lot more pieces in customer service. I just wanted to pull up and highlight some of those for you here. And we're going to talk a little bit more about some of these in the next slide. And the last bubble, but probably for me, one of the most important bubble is my workforce. If I don't invest in people and culture, I'm not going to be able to do anything else in the other bubbles. So I need to have a workforce that's competent, that is satisfied with what they do, and consistent, right? So that has been our focus when we're looking at, when I don't have enough staff, this is where we see all of these things start to fall short. So I have to have enough staff to be able to maintain the minimum of what we're doing. And just in terms of staffing, just as a quick aside, we have looked at over the last couple of years other states of a similar size and demographic population, even with a Medicaid population served. And so we know that we're not overstaffed. And we know that we're not woefully understaffed. Notice I say woefully, right? We're sort of right in the middle, all right? So we're making it work with what we have, but I don't want to be woefully understaffed, I guess, is some of the ask there. So just keeping that in mind, that we're not overstaffed at this point, we're able to carry out our mission. So you're going to hear about our roadmap repeatedly throughout budget sessions, because it's what our staff know as our priorities. It's what our stakeholders know as our priorities. And it's what I want you as our Division 3 Budget Committee to know as our priorities going through. Yep.
I don't know if this has been done. I'm not asking for new work, but if it's been done, I'd like to see it at some point. I love the roadmap. I've complimented you every time I've seen the roadmap. This is really excellent strategic work. Thank you for that. What would be helpful as we go through this is the budget as it presents in HB1 is a very kind of linear spreadsheet, and what would be useful, I think, as another way to look at this is if there was a pivot, so that we could see these line items of the strategic plan and have some sense what each of these bullets are going to consume in terms of resources, financial and personnel. So this is the way I think you view your department and leading your department. It would be nice if we could see how the resources then kind of pivot up underneath it and support the strategic plan. I think Ms. Tellis is scheduled to come in and tell us about your roadmap and the performance metrics that you've established for these things. At least that's what I think she's going to do. If it happens that she could maybe, oh no, it's still too early to talk numbers. But eventually, it would be cool if we could get numbers associated with the strategic plan. Is that hard to do, easy to do?
So we're anticipating following a similar presentation style to what we did in the prior biennium, where what we did is we tried to line up all of the accounts in the bureaus, and we tried to tie those into a narrative around the program. So I think what we can do is, as we go through that, is we can highlight key elements. But part of the roadmap too is prioritizing certain things. So there's certain staff that exist today, they existed before the roadmap started, that are now prioritizing the roadmap initiatives, maybe over some of the work that they may have done otherwise or other initiatives. So, but what we can try to do is just highlight that. Maybe we can use a little identification system, a little asterisk or something along those lines, to try to get at what you're identifying, Chairman Edwards.
So this kind of question came up in a previous presentation on Mission Zero, and Mission Zero is this very comprehensive program that brings all these components together for success, and it's beautiful the way that's working. I think I asked at that time if there was a way for us to do a cost estimate of what Mission Zero was costing us from an execution perspective, and that sounded like a very tough question.
Well, I think we could speak to the direct cost that the department had with its relation to Mission Zero. But when you think about if you're going to quantify all of the time of all the external stakeholders and count that as a cost as well, that might bring a level of complexity to it. I think so. We can quantify some of the costs for that internally for the department. Like we stood up positions for one of the initiatives that we didn't have before to be able to do that work.
All right, thank you.
Right. So at this point, I'd like to go to the next slide.
The clerk has
Maybe.
a question. Do you have a question?
Chairman, may I ask a question? I have a quick question. In looking under the Mission Zero, again, a quick comment. I'm Representative Rich Nelevenko from Cheshire District 9. And the question is, under the bullet that says reduce the health impacts from environmental threats, what, a summary of what's included under environmental threats?
Sure, we're going to go through all of those detailed questions at subsequent presentations, so we will make sure to write that down. Thank
Great,
you for the
thank you.
question.
Thank you.
So the next slide of efficient stewardship of resources and strong customer service, that theme that we're sort of laying out, I'm going to ask Dave Wieters to come up and join Nathan here to walk you through some of these systems here. Although we could sit together, we won't.
I'm too big, but you would fit just fine. Good morning. My name is David Wieters. I'm the Chief Operating Officer for DHHS. Thank you for having me here, Chairman, Mr. Chair, and the members of the committee. So, taking off of what Commissioner Weaver just indicated, in order to achieve a lot of these roadmap items, as well as providing good customer service, we really need to have a way in which to be efficient with that. So IT has always historically been the promise of automation, the promise of efficiency, the promise of making it easier or faster to do things. Our goal is to try to do that in concert with the services that we're doing. And so the information systems that we have here is really one of the things I've learned over the last 6 years of working and living in New Hampshire is making sure that we address everything from a privacy first perspective and then security, and then making sure at the same time, how do we efficiently meet the expectations of our constituency, meet the expectations of our legislature, meet the expectations of our governor's office, and really meet the expectations of our commissioner as well to achieve those goals of customer service. So we currently support a little over 130 applications in the department across all of the different programs in the area. We partner with Department of Information Technology to be able to support those, as well as several contracts that we work with the contracts division to do. Amongst those 130 applications, we have really 8 key platforms. And the reason why I call them key platforms is they're really key enablers for us to automate and actually reduce duplicative effort and provide efficiencies where possible. So we're not building multiple different systems to do very similar components. So about 6 years ago, I actually said our applications were closer to 200 applications that we supported. So we've actually reduced our application over the last 6 years. Those platforms include, and you'll hear in my presentation tomorrow, some more details about these, but those application platforms are the Medicaid Enterprise System, which is really made up of 14 different systems in itself that are achieving different components of Medicaid solutions. And then we also have the Enterprise Business Intelligence System that we will call EBI. I'm going to try to always define any acronym that I use. I definitely, as an IT person, have that challenge. And so anytime you have a question, feel free to say, what is that NH here? So then the next one, NH Care Connections, or New Hampshire Care Connections, is our system that really focuses on improving our coordination of care, but also really focusing on admission, discharge, transfer, shared care insights, and closed loop referral. So you'll hear a lot about that. You've probably heard a lot about it over the years. I know a number of you have been in rooms with me talking about closed loop referral, but it is much more than just closed loop referral. So you'll hear more about that as well. And then we have Granite Families, or Bridges. So we have a current comprehensive child welfare information system, which we call Bridges. It's a 20-plus-year-old system that we've been migrating to what's called Granite Families through funding with Administration for Children's and Families support. And then we also have New Heights, which you'll hear me say New Heights a lot, but it'll also be inclusive of New Hampshire Easy. So New Heights is our integrated eligibility and enrollment system, but it's become so much more in the last couple of years, where it also supports developmental disabilities. So instead of implementing a whole new system based off of doing RFIs and work with different contracted vendors, we identified a way in which to expand upon the New Heights platform to achieve that goal with a reduction in cost, overall cost. And then we have options, which is for our aging and adult population. We're still using that system. It is a DOIT supported application that we're looking to replace over time, and you'll hear more about that. And then the last two are Avatar, which is an electronic health records or electronic medical record system that we use currently at New Hampshire Hospital. And then Salesforce. And Salesforce as a platform has enabled us to implement dozens of solutions within our department in a much quicker fashion than in the past, where we would have to go out to RFP, implement a silo-based solution, and then take it forward for maintenance and operations. With the Salesforce platform, we're able to, in some cases, deliver solutions in 3 days. During COVID, we actually implemented Granite Trace for case investigation and patient monitoring for COVID in 3 days over a weekend to ensure that we could collect that, and other systems like our childcare licensing and registry solution for childcare and Head Start development. As we go through this and streamline these solutions, you'll hear more about what you were asking, Representative Edwards, how do we tie it to our roadmap? So tomorrow's slide will go into more detail as to what are the technologies behind some of these roadmap initiatives, and where the human resources taking, how's the architecture supporting it, and how are we moving it? And I'm probably going to not go into the details of the architecture, but I certainly will address the different technologies that are supporting these roadmap components. And then going into that second column, portfolio management is a key component of how organizations really manage their initiatives, how they manage the prioritization of their work, and how they manage the overall health. Over the past several years, we've been standing up the enterprise portfolio management solution, and our goal is to leverage PMBOK, which is Project Management Book of Knowledge. It's a standard best practice in the United States, and agile project management methodologies to really adopt some of those risk management, issue management, scheduling, resourcing, and then overall health of a project. We've been using that to manage an average of 200 projects annually, and we've really been aggressive at using it for our roadmap initiatives to ensure that we can see that it's staying on track and how we're moving it forward. I'm not going to go through every bullet here, but we have invested in a lot of training to ensure people have the resources that they need to be able to adopt these methodologies. And then using our oversight and leadership, we've been able to coach and move a lot of projects forward faster using these technologies. And I'll hand it over to Nathan to go through our contracting.
Great. Thank you, Dave. At the Department of Health and Human Services, we have a centralized contracts unit and our bureau. And what that team does is they prepare all of the solicitations, so all the RFPs and the RFAs and the RFBs, and they also handle all the contract amendments and grant agreements and our lease agreements and our regular contracts and a whole slew of other MOUs, intergovernmental organization agreements as well. And part of the reason that we've centralized that function, going back to the commissioner's point, is to ensure that the contracts are developed in a solid way and have meaningful performance measures, have enforceable provisions, and ensure that we're getting the things that we want. And there's standard templates and procedures and members that are trained on this regularly, and they work with the program areas and leadership across the department. And they put through a tremendous amount of volume. And I think it's important for this committee just to remember that every contract over $10,000 has to go through the executive council process. And if you change one word in any contract that's been approved by the executive council, that amendment needs to go back through the executive council. So this team moves 800, in some years even more than that, amendments and contracts through that process. And they've implemented a Lean Six Sigma DMAIC culture. And I think that's really important because basically what that means is they're constantly measuring what they're doing, they're rethinking what they're doing, and they're striving to do that faster and more efficient. And it also, what's really important if you've been involved in Lean Six Sigma, the voice of the customer is a very important component here. And we've developed this system both for internal customers, but also the provider community and those individuals in the community that are responding. And that system's been intentionally built up that way over a period of years to address deficiencies that leadership had identified 6, 7, 8 years ago. And we've made some really good strides. Now, they also conduct risk assessments. So anytime we're giving out money to a provider, we conduct a risk assessment. We look at the operational risks, and we also look at the financial risks. And that's really important because we then set the contract up based on the risks that we've identified and the level of oversight and monitoring. And I'm going to kind of switch the budget for just a sec. But when you look at our budget lines, we do have hundreds of millions of dollars in our contracts lines. And that's why it's so important to make sure that when you're developing that contract, you get it right, you make sure it's enforceable. And now I'm going to switch to quality and performance, but it's also important that you include meaningful performance measures. And so Meredith Toulouse will be here tomorrow, and she'll be talking about some of what her team does. And her team is now working with different program areas to try to incorporate those provisions that will make those contracts have better outcomes and give us the ability to measure what are the outputs, what are the outcomes, is that really worth it? You know, that's what we want to try to make sure that we can do. She's also going to be talking about, we do audit our providers on a regular basis. When we identify risk, there are certain requirements to make sure that those dollars are spent accordingly. We also actively look at the financial integrity of some of our smaller providers or some of our high-risk providers. We look at their financials on a monthly basis to make sure that there's no solvency issues. And if we start to see trends, we do intervene at time and have a conversation to get a better understanding because, as the commissioner was indicating, we do rely on our providers through our contract or through our contracts or our grants to deliver key critical services. And so, you know, we're partners, but we're also ensuring that the dollars are being used effectively and in responsible ways. So Meredith's team also has a fraud, waste, and abuse team that regularly looks into suspicions of fraud, and she's going to go into a little bit more of that tomorrow. But I just kind of want to provide sort of a high, broad overview of all the different activities that the department does relative to ensuring funds are managed appropriately. So, and with that, we can move.
May I?
Oh, yes.
Okay, I have known that you've been improving the contract management since your arrival, and it continues to sound like you're reaching a higher level of professionalism. The one thing that has caught my ear this time around, and the commissioner mentioned it, is I'd like to maybe when you come back to talk about contracts more deeply, I'm interested in the way in which you're interfacing with the public, because it sounded like you've made a point of making our contract availability more known and easier to access so that we can increase bids and interest in public participation. That's kind of new to me. That's an area that you've worked on, and if I've heard you right, I'd like to just know more about it, but not today.
Absolutely. We've provided a presentation to another committee, and we can refurbish that and bring that back so we can give you that information. Absolutely.
All right, thank you.
And with that, I'm going to hand it over to Chris and Tricia, our associate commissioners.
Thank you so much. My name is Patricia Tilley. I'm an associate commissioner here at the department.
And I'm Chris Santinello. I am also an associate commissioner. This feels like oversight.
It does. It does indeed. I'm going to start first, and then I'm going to hand it over to Chris, and we're going to work synergistically together. Before I get started, though, because we all felt the rockin' and roll in a few minutes, I'll just give you an update. It was a 4.1 earthquake in Portsmouth. There are no health needs in the towns or hospitals in the region. So there you go. That's what we're doing in the back while you all are presenting. We're making sure that everything's safe and sound. For right now, the other piece that I'll start and answer before I get into the slide a little bit was the question earlier around environmental threats. I can tell you that we'll talk a little bit more. You'll hear more about that probably when public health comes and does their description of their budget. But to answer your quick question, what we're very much focusing on is PFAS. We're focusing on lead both in homes, lead in water. We're focusing on food safety and contaminants in foods and supporting our health officers in our towns. So you'll hear more about that when public health comes and presents later on. So let me jump in right now. For right now, we're going to focus on Thursday, Chris and I, around the specialized services and the population health work that we do within the department. And we're going to dive in. We're going to talk a little bit about youth. We're going to talk about older adults. We're going to talk about the specialized services that they need. At a high level, we're going to focus on the ways that we streamline services as a single agency. The department creates a more integrated and coordinated system, hopefully making it easier for families and individuals to get the care that they need and the services in a coordinated fashion and sometimes in one place. We believe that this reduces confusion and helps us prevent the need to navigate multiple bureaucracies. We think that together we are working on efficiency in our resource allocation by having all of these programs under one roof. Again, as a small state, we pride ourselves on efficiency, as we've heard over and over, and in this budget season especially. And by combining services under one roof, it's maximized available funding, staffing, and infrastructure. And this includes some of the things that I know that Representative Edwards is interested in around evaluation and monitoring those many contracts that Nathan was just describing. We're also going to talk a little bit about our data sharing with all these services under one agency. There's better potential for appropriate data sharing. We have lots of conversations about security and privacy in many of our efforts, but by having someone like Dave Wieters in charge who has an eye on all of those systems, we're able to more efficiently share information and to improve the services that we have. And that really leads to a more holistic approach to service delivery. Many of the individuals and families who require services in one part of the department also require services in another part of the department. And that's why working together, we are focusing on how to make sure we streamline that along the way so that we get to improved coordination. Our roadmap in particular, as the commissioner noted, focuses on Mission Zero. We're going to dive into that a little bit more on Thursday. The spoiler alert is we have gotten to zero in the Mission Zero. It's hard to sustain that. And that's why you're going to hear about the multiple funding streams. To your question earlier, Representative, the reason it's hard for us to give you a single answer is because the foundation is so complex. We use Medicaid, we use individual grants, we use general funds, and they're from all different parts, all coming together to be able to lift up this initiative so that we can reduce the burden of emergency department boarding for people who are experiencing acute mental health needs. We all know that is not what we want. And we have used Mission Zero to focus energy to use every lever we have to lift that up to make change. We're going to focus, as the commissioner also noted, on the system of care, coordinated systems for children in behavioral health. There is not one of us who hasn't experienced in our own families or our friends and neighbors the impact of the mental health crisis among children in this state. And so we are looking to better coordinate that care and make for both the population of kids that we are in charge of, that we have care and control of through DCYF, as well as for your neighbors and for your constituents. And through that, we're really looking at aligning or embedding prevention everywhere, centralizing a place to call for help, scaling helpful services, strengthening supports to stay home and out of those institutions where possible, and coordinating expert care when we need it. So you want a few of the other things we'll poke at on Thursday is really focusing on DCYF a little bit. You know, that's plays hand in hand with our system of care, of behavioral health. But there are also some particular issues that I know may be interested of this committee around the Sununu Youth Services Center and that transition to a new facility. So we'll dig into that a little bit. So I'm going to hand it over to Chris and let you take it from there.
Great, thank you.
Could you just give me just one moment? Out of respect for the commissioner's time, I think you're getting ready to leave. Do you have any final words or thoughts for us before you?
I have a couple more minutes. Thank you. We're almost, I should make.
Okay, all right. Sorry for the interruption.
No problem. I think also what we want to cover on Thursday is the system of care for healthy aging and how, as an aging state, we are working collaboratively with our partners, with the State Commission on Aging, to increase our ability to provide home and community-based services instead of institutional care. We're going to talk about that. We're also going to talk a little bit about the preventative programs that we have under Older Americans Act, which actually help provide supports to older adults before they need more significant level of care, before they have Medicaid. So something like Meals on Wheels is a really important program because for many people who access it, that's the only contact they have with somebody. So it provides a lot more than nutrition. We're going to also talk a little bit about how we're working together, like I said, with the State Committee on Aging, with some of that work, and also adult protective services that is required under state law. But what is the interface for how we support vulnerable adults, as well as our aging and disability resource centers, how they're critical as part of the system of care to help increase access, the right service at the right time at the right place. We'll also spend a significant amount of time on our developmental services system and how we're strengthening that and building rate work to help us have predictable, standardized approach to services using an assessment-based approach that will help us over time to really have better budget predictability. So I think that's it. In the interest of time, I will have Ann step up.
May I say something about public health?
Sure.
One of the things I've been thinking about is grappling with the challenge of the coming budget cycle is that we just went through an enormous change in our public health expectations because of COVID. And so I'm just wondering at a very simple sophomoric level as I go into this, what if we were to take as a baseline 2019 and looked at the programs that you want in 2025 as being additive to that so that we can understand which ones are driven by the crisis and which ones are just driven by greater public health awareness. And we don't have to do that today, but I just wanted to share with you sort of my simple sophomoric view of how to think about your public health mission.
Thank you. And in the only respect, I think that's great. We can talk about that further in the public health discussion of the budget. The thing I would leave you with is that the greatest, there were not many gifts of the pandemic, but one of the small gifts was the ability to modernize our data systems. And so I don't think of that as additive. I think that it was an opportunity to use an influx of federal funds to get our data systems to the place they needed to be.
It's so counterintuitive. I just want to, I didn't realize that clock was wrong. So it's actually 10:55. So I do have to run across the street, but I wanted to, Ann's going to come up and work the next slide, but I just wanted to say thank you for the opportunity. And I'm going to pray that it's not a bad omen that there was an earthquake in the middle of my presentation and my chair was shaking. So, but Ann, you want to come up? And so I think after Ann's piece on the Medicaid, if we could just get from you your thoughts in terms of things that are questions you may have had that you want to make sure that we address in subsequent presentations. So thank you.
Good morning. My name is Ann Landry. I'm one of our associate commissioners, and I'm here with.
I'm Jonathan Ballard. I work as the Chief Medical Officer.
And while you may be surprised that, well, at least I'm here on behalf of Medicaid because you're used to Director Lippman, I'm just going to give you a brief overview of our Medicaid program and walk you through some of the concepts and intricacies of the program that Henry will walk us through on Monday or next Monday. So here our slide really depicts how Medicaid funding intersects with all of the different programs that we execute in the department and beyond. But really, as you know, Medicaid is the insurer for our most vulnerable residents and citizens in the state, and those with the most complex needs. Is that lifeline for those individuals who cannot access healthcare anywhere else. So clearly a critical program. It really covers specific populations. It's not just anyone who can get Medicaid, obviously. It's individuals with low incomes, whether that's pregnant women, children, families, and a certain group of adults. It's individuals with disabilities, and then elderly individuals. And as we know, the Medicaid program really has two different components. It's the required federal components of Medicaid, whether that's inpatient and outpatient hospitalization, for example, and then the New Hampshire approved optional benefits, which, as you know, the most recent is really dental benefits. So there's a wide range of required and then optional benefits that Henry will walk us through. We also know that that we deliver these services through a couple of different mechanisms. There's state plan amendments that some of our services are covered through, and then federally approved waivers, which, for example, our managed care organizations, our managed care program is covered through a waiver. So again, on a week from today, Henry will really walk you through what are the differences between services covered by state plan amendment, what are services covered under waivers, what are the differences, where is there overlap, where do we leverage those different mechanisms to best serve the residents of New Hampshire, and how do we hold ourselves accountable, which Jonathan will talk a little bit about in a minute. And then, of course, as the wheel says, or indicates, we have all of these different programs that rely on Medicaid funding. So we have our Division of Medicaid Services, but we're just not in a vacuum at the department or in the state. We're constantly interacting with Chris's teams and Trisha's teams. We have Jonathan as a medical oversight that works really closely with Division Youth and Family Services on what those children's needs are. So we're not a siloed division, and we're really hand in hand with all of the different divisions at the department, understanding what those programmatic needs are, where the Medicaid funding is. I think what will be really interesting and what you'll be wanting to understand next week with Henry is really, how does that federal match work? What does that mean? What part is the state paying versus what the federal government is paying for our Medicaid program here in New Hampshire, and how that may change depending on different programs and what that match looks like. I'm going to stop there. I'm going to ask Jonathan if you have anything.
Sure. I'd like to mention accountability. So of the 184,000 individuals that are covered with Medicaid in New Hampshire, it's actually a small population in Medicaid terms compared to most states, even of states that are comparable size to New Hampshire. And that's because New Hampshire is a healthy state. In the rankings, we are among the healthiest states in the country. But that's not true among our Medicaid population. And so we want to make improvements and continue New Hampshire being the healthiest state in the country. We really have to be accountable to you and to taxpayers with good stewardship of those funds. And so that's why you'll hear from Director Meredith Toulouse, Director Henry Lippman in subsequent talks about accountability, how we do that through contracts and other mechanisms. So there's a real connection between our medical services unit in Medicaid with driving the accountability in those contracts for the good stewardship of those funds. Don't want to get into the weeds, we will in the future, but the example is that with the MCO contract, we want to make sure that we are reducing cost and using those funds efficiently. And one mechanism that we do that is to have a coordinated system for those individuals that are covered through Medicaid. We collect over 300 metrics from the MCOs on how the population is doing, from claims data to actual quality data for how healthy people are. One central metric example is the percentage of patients that have a primary care doctor, who see that primary care doctor and have a health physical, a checkup with their primary care doctor. That's an example of a metric that we use very heavily in our contracts as far as assessing liquidated damages to MCOs if the patients do not have that, or rewarding them through mechanisms such as performance-based auto assignment, assigning more patients to an MCO who's doing a better job of connecting patients to a primary care doctor. The idea here is we're reducing costs by having a coordinated system. Primary care is far cheaper than an individual being hospitalized or having a unnecessary emergency room visit. So that's just diving into a little bit of a way that we want to be accountable and be very mindful that these are taxpayer funds. They're not ours.
Thank you, Jonathan. And just to highlight the number of individuals on Medicaid in the state of New Hampshire, John said about 185,000. Just to put that in perspective, almost 90,000 of those are children too. So it's important to know that we're really ensuring that our future children are getting the best health that they can possibly get to ensure that their livelihood and self-sufficiency when they're older is there. So I think that's really critical. We can stop there. We have a really detailed presentation prepared for next Monday on Medicaid 101, the difference of Medicaid and Medicare, and all of the different, as I said, funding components, types of populations covered, eligibility process, funding mechanisms, and such. So if there's any additional questions that you would like us to address next Monday, we're happy to include that in our presentation. I know Representative Edwards has worked with Henry a bit to provide an outline of what you may expect. So we're happy to add to that as well. Or if there are any other questions for any of us.
I think you're meaning to open that up to everyone who's spoken
Yes,
so far.
I am.
Yeah. Are there any questions from the committee, Representative Daniels? And just a reminder of how we do business. I put it in an email. Once I turn the microphone over to one of the committee members, you're free to engage in a natural conversation with the people at the desk. You don't need to keep coming back to me to ask for follow-up. And as long as we're maintaining a common track, that's great. I think that's a preferable way of going. So it's a little different than other committees, but go ahead, Representative Daniels.
Thank you, Mr. Chairman. I actually have a number of questions. Some of them are probably short, others may be a little longer. Regarding the staffing, we were given a number. Does that include full-time, part-time?
Okay, I'm sorry, because I can see the logistics here right now. We're going to maybe start having members of the audience come up. There's a bank of microphones along the seats. If you get asked to come up, just grab one of these side seats and stay there until we're done. Right, we do want to do that, but if there's an answer and acknowledgement, let's do that too.
Okay. So yeah, I'd be interested in the breakdown, whether that 3,200 employees include full-time, part-time, and or contracting, and what the numbers are. Mr. White, I have a question for him. In the example he gave on TANF, he said we had to spend 34 million in order to get 38 million, but then he mentioned something about a penalty, and I'm wondering if we are penalized for not spending according to federal expectations.
I can answer. Okay. Chris Santinello, Associate Commissioner. Right now, we are not in a penalty phase with TANF, but I can have Nathan better explain it because it starts a spiral. And it's really hard to get out of that spiral once you go down in that. But Nathan can be prepared to talk about that.
And the slide that you're asking about positions, those are only full-time authorized reflected on that sheet. If you would like something in addition, we can ask Nathan to pull that.
Okay, thank you. And to just follow up on that, the full-time, does that include any positions that may be vacant right now?
Yes.
Okay, thank you. I think I'll wait till Thursday because I've heard a lot about performance measurements, and one of my questions was how you are measuring for success. In one of the earlier slides, the commissioner mentioned a culture of belonging, and I wonder if somebody could elaborate a little bit more what a culture of belonging means. Let's see.
Dave said he will address that tomorrow. Okay.
Okay, thank you. On the slide that talked about the youth and older adults, what is the age range for youth and for older adults?
That depends on the program, but some of our programs goes for youth is 0 to 18. Some go up into the 20s, depending on their particular needs. Chris, you could probably answer
Same
that
for
disability.
aging and adult services. Some start at 18, some start at 60. So I will map that out for you on Thursday.
Okay, appreciate that. There was a mention about a PCP visit to kind of keep a benchmark going with Medicare recipients. They have an annual wellness visit, which, as I understand, really doesn't do much except mark something down on paper. There's not too much physical examination or anything like that. So I'm curious as to how that fits into the program.
I can answer that question now. So Medicaid does not have a Medicare wellness visit. So what we're really looking at is mostly for the 90,000 children. Since the pandemic, it's incredibly important for them to have in-person wellness visits because that's where they get things like lead screening. It has to be done in person. So they have depending on the age, primarily has a different types of services that are recommended for that type of visit, but it's not like the Medicare wellness that doesn't even require a physical exam. These require a provider, a doctor, other providers, physically examining the patient and performing services like screening for elevated lead levels.
Good to know. Thank you. And then my last one has to do with long-term care in kind of the coordination between programs. About 5 years ago, I assisted my dad going through to get on Medicaid, and we get into a situation where the facility would not accept him until we got the okay from the department that he was accepted for Medicaid, but they would not accept him for Medicaid until the facility said that they would take him. So it wasn't until we got involved in a three-way call and the department says, well, we also have Senator Daniels on the line. And suddenly all the doors opened and everything was okay and came together quickly. And I'm wondering, does that kind of situation still exist? And if so, how do we get past it?
I will address that on Thursday as well when we talk about, and some of the work in our system of care for healthy aging actually altered how we do eligibility to help get the access at the right time. But I'll talk a little bit about the coordination of our financial unit and our medical eligibility unit and how we're working together.
Okay, thank you very much. Thank you, Mr. Chairman.
Are there any other questions from the committee? I have a couple, but go ahead.
I just want to make sure I heard that correctly. Did I hear correctly that Medicaid does not cover adult wellness and an annual adult wellness? Medicare.
Medicare has a very specific Medicare wellness visit that is different than a preventive health visit that would be in Medicaid. The Medicare, there's two types. There's a welcome to Medicare visit, and then there's the Medicare annual visit. So that's strictly Medicare, and that type of visit that Representative Daniels spoke about is very limited in scope. For visits that happen in Medicaid, it is a full-on physical exam and addressing the different health needs of that individual person, whether it's a child or adult.
Thanks for the clarification.
And of course, you want to brag about how in the dental program, the adult dental program, we included a preventive component.
Absolutely.
So the Medicaid population, I'd like to know more about the kids part of this later this week. 90,000 approximately of about 185,000, I'll call that half, are kids. I can't imagine that the kids are contributing half of the cost, though. I gotta imagine that the adult side is relatively more expensive on a per capita basis, but maybe you could share those details with me later.
We'll take that down, Representative Edwards, and bring that back to you in the next talk. But I can tell you, though, that many of the individuals that are children that Medicaid covers have very complex medical needs. Some are very high cost and require specialized services in other states, children's hospitals in other states. And those bills can run up in the millions or tens of millions for a child very quickly in some very rare situations. But so we do need to get the exact numbers for you as far as the breakdown.
Thank you so much. And then the other part of it is, I think it was mentioned that New Hampshire has a higher percentage or a very high percentage of children in the program relative to other states. I think that's probably due to the eligibility guidelines, that adults are at about 185% of poverty level, but we allow children up to in the 300s or something, a much higher percentage of poverty. Could you, when you come back, just make sure we understand what that eligibility cutoff is, and if there's any history around when it got extended or contracted in the last 10 years or something, that would be nice context.
Absolutely. We're prepared to talk about the federal poverty limit, what that is for adults, which I think is around 138%. And then the children are much higher, as you mentioned, but we'll bring back those exact breakdowns and the history of it.
And then if you could also, thank you, if you could also contextualize that against the other states. I mean,
Yes.
that's not the only benchmark, but it would be just nice to know where we rank. So,
Sure thing.
are there, Representative Stringham?
Yeah, I have a few questions in writing. Who should I give them to so you can integrate them in, or anybody? Or?
Yes.
Okay, that's all. I don't have to summarize them now.
I'm not seeing any other questions, so I have one for our new clerk. Are you comfortable? You have everything to put the minutes together for this meeting? Is there anything that you need restated or anyone reintroduced or anything to complete the record?
Yes, thank you, Mr. Chairman. I didn't catch all the names of the presenters, but I think I can take those off the org chart.
If one of you could stick around and help us with names, that would be great.
Sure.
Thank you.
All right.
I think
Okay.
I have most of what else I need.
Outstanding. Thank you so much. The clerk job is a very difficult job. I appreciate it.
I'm easing into it.
Yeah, yeah. All right. And then, so I'll ask the department, last call. Any last call? Committee, last call, Mr. Ripple? I never want to finish without your last word. Are we okay? All right. So with that, I'll adjourn this division hearing.
Thank you.